All right, wonderful. Everyone, welcome to Grand Rounds. I know we're still waiting for some more people to kind of join us down here in B107, but hopefully, I see we have several people already joining us online. So I think we're going to go ahead and get started. It is my great pleasure to announce our first speaker. Hi, Dr. Jackson. I see your chat there. My first speaker is very exciting. We have two speakers today, just so you know. So my first one is really doesn't need an introduction. It's Dr. Kellee Oller. As you guys know, she's our amazing program director for our internal medicine residency. And this is her annual report telling us how things are going with the internal medicine residency. Without further ado, I will let her go ahead and get started, and I'll introduce the next speaker when she finishes.
All right. Hello and welcome. This is always a fun talk that I give at Grand Rounds. It's a nice opportunity for reflection. Usually it's right after we finish up our program evaluation committee and have looked at all of the data from the year before. So it's a nice opportunity for us to reflect, see how we did, see if there's opportunities or areas where we want to grow or kind of develop during the year. And usually I like to share this time with somebody else. So another speaker that really has an important message to share related to the residency program or curriculum. And so these are my objectives at the start, and then Colleen's going to come up afterwards and share kind of the next topic. And I have no disclosures to announce yet. Rob Lowe, you'll find out at the end, might give me a call. We'll see. In terms of program size, over the last almost 2 decades now, we've really seen remarkable growth in the amount of residents in the program, consistently maintaining around 116, 117 residents per year. The big kind of burst in the growth was really when we transitioned to X+Y. So we first transitioned just the senior residents into that model. The interns were still in the traditional model. It was always a fun time when they became seniors and they were like, X+Y is so great. I wish our interns had it. And then another big kind of burst around 2018. And that's when we transitioned the interns to X+Y. So we really expanded our opportunities for prelim interns to really help support that transition for all 3 classes to X+Y. Our graduates, a large percent of our graduates stay in Florida. Almost half stay within USF in some fashion, chief residency years, fellowship, through their careers. This was a very interesting year because if you include primary care and hospital medicine, it's actually more than fellowship. So a little bit unique of a class that just graduated too. But looking at kind of data in the last 3 years, you can see that we usually have a large chunk of residents that continue in training and fellowship in some sort. So this is more kind of longitudinal data from Residency Explorer, I believe. I'm super proud of our residents and their performance on the boards. It's a little bit small to see, but you can see in the last kind of 3-year bucket, we're at 97%. So this looks at 3 classes, so 100 residents and their performance on the boards. As you can see, the national average has even been trending down, right? 87%, 85% for that 3-year board pass rate. So super proud of our residents on their success. They find out next week how they did. And for our seniors, you find out next week how you did on your ITEs too. No pressure.
Can you send mine first?
Yes. Scholarly activities, so another big year with several presentations and publications within the academic year. So super proud of our residents. I found a way to get really fancy with PowerPoint and show. It's a little laggy. But on my screen, it looks like credits that are scrolling. I'm so sad you can't see it like in its full glory. But very proud of all of their accomplishments. And here's some kind of representative pictures. Obviously, not all of the pictures from their times at conferences. Faculty included, some of our fellowship faculty. We have pictures of our alumni who connect with us at conferences. So really neat to really see a whole spectrum of current graduates, incoming faculty that are joining with us but haven't started yet. Some more. In terms of recruitment, so this is last year's data. We interviewed 216 students for the categorical positions, and last year we did 34. I think 35. We bumped up from where we kind of were doing 33 for many years beforehand. And then this is the number of applicants to the categorical program. We have some preliminary data, obviously, because ARIS just opened yesterday. So of course, when I updated the slide yesterday to include these numbers, they've already changed. So now they're already 21 something. So it's a little bit hard to compare because some of these numbers are at the end of the season. So obviously there's still a few more months where applications might trickle in that didn't hit opening day. You can see kind of the evolution of silver signals. We originally started with just only kind of one type of signal. And then in the last 2 years, we've had tiered signaling. So you can see with just only one type of kind of low volume signals, it really didn't change much in terms of total application volume that at least we as a program are seeing. Again, this is just our data. Last year when the gold signals were added, we saw a little bit of a dip. And then even this year, again, a little bit of a dip. This number is still a little fresh though. But super interesting to kind of see the evolution of this with maybe students learning a little bit to be conservative in their applications that they're sending out, kind of having the highest value in those 15 programs that they're signaling. And it also allows programs like us to be more targeted with applicants that we're interviewing. And so last year we dropped kind of the number of applicants that we even interviewed just because we knew it was going to be a much more targeted population. And then a big component of today's Grand Rounds is just really sharing a lot of the action items or the things that we are working on, growing, new initiatives that were kind of launched this year that we're getting feedback on, and distributing that out to all of the residents and faculty. So first, an initiative that we had this year was to really expand the exposure in primary care and continuity in the continuity clinic block. So for the intern class, they added an alternative clinic site, and not like alternative medicine, but really a complementary primary care clinic. So if they were a Health Park or Morsani intern, then they had 1 day per week of VA primary care. If they were a VA primary care resident, then they added 1 day per week outside of the VA. And so the value in this was multiple fold, obviously exposure to very different patient populations, different ways that outpatient medicine is practiced in patients with different resources. But it also is helping. And so I'm meeting with all of our interns. I'm almost done actually with my intern semi-annuals. And I think it's really helping with just kind of early navigation in the outpatient EMRs. So for the interns that don't have their site at the VA, right, they're learning early on about how to manage view alerts, how to set up surrogacy, so that way if they have a time period where they're away from the VA, they can send their alerts to somebody else for things that they're ordering in the clinic to monitor. And then for those that are primarily at the VA, that 1 day at Morsani and Health Park per week is really letting them see outpatient Epic, which is very different than inpatient Epic, which will really help facilitate the transition into more subspecialty based clinics as a PGY2. So definitely lots of benefits there. Another kind of bonus was this is we moved kind of our procedure half day out of this block into its own rotation. And that's really allowed our residents on that rotation to really get a lot more volume of procedures. So a lot of the interns that I'm talking to already that have had their 2 week block of procedures have already had opportunities doing thoras, paras, getting central access for dialysis catheters. I think one even did a bone marrow biopsy. So really neat opportunities that they're getting because they're there every single day. So they have the ability to kind of step in, see how things run at first, kind of observe, and then the next day they're like, okay, I'm ready for a procedure. Whereas if they're there just kind of a half day per week, kind of spread throughout the year, I think it's hard to just jump in and get your hands dirty. So feedback today, I think, has been largely positive. I think there has been some initial challenges as we're building this with having patients for those residents to see when they're at that complementary clinic day. So the clinic faculty now are really working on expanding the opportunities for those residents, creating acute clinic panels, and things like that. Because we also want our residents who are there for continuity clinic, to not have to share necessarily their continuity clinic patients for somebody that's there, right? So that's a growing opportunity that we're working on. And then we're also decompressing it a little bit. So some of the days had 2 interns there that were kind of floating there for the experience that day. And then it was just too many people wanting to see acute visits or patients. And so we kind of separated those out, utilizing one of our TGH clinics that's in our Kennedy Clinic rotation. And the feedback that I've gotten from that, which started this month, has also been very positive. Kind of a segue off of this was a little mini pilot with the PGY2s in Morsani and the PGY2s at the VA Blue Clinic. So again, a very small population of PGY2s where we took and gave them more of a hybrid schedule. So unlike the interns where we had the traditional clinic block and just added a day, for these PGY2s, we kind of did a 50-50 split of kind of their primary site and then the complementary site. So I think feedback on this one is a little bit more mixed. To start it as a PGY2, I think it's harder to maintain continuity with your patient panel that you already had, since 50% of your slots are now, you're not there anymore because you're going to an alternate clinic. But some of the feedback has been very positive, where residents have liked the different experience, the different pace, the different styles of the clinic. So this one we still need to collect a little bit more data on. It's only been a couple of months. I think some considerations would be if interns wanted to kind of keep both outpatient experiences, maybe it would be in a select population who's interested in primary care to kind of continue to have that really mixed model of experience. So more to come on this one as we get further into the year. Updates to curriculum. Thanks to one of our fabulous chief residents, Oller, for tracking conferences and the didactics that are in place and comparing it to the ABIM blueprint to see if there's gaps in curriculum that we can kind of filter in with more speakers and new speakers to really target as many topics as we can within the ABIM blueprint. In terms of addiction medicine, Dr. Burbank is continuing her 3-year curriculum that she's doing within that Friday academic half day. So that launched in the spring. And then just this block, we're kind of strategizing ways to incorporate addiction medicine into the core rotation. The core rotation is a blend of QI at the VA as well as non-internal medicine clinical outpatient rotations. That's why it's called core, which is an ACGME requirement. So it includes things like dermatology and podiatry, but really kind of, I think this was initially a good home for this experience, kind of working with psychiatry and the substance use program. So still kind of finessing and cooking out what that experience would be with those that are currently on the rotation that have kind of started the pilot. Last year, we changed our workshop. So the PGY1 workshop used to be within the academic half day. So it'd be given 4 different times right after really a procedure workshop. So the procedure workshop really had a much larger focus. And we really wanted to make sure that the transition to senior workshop really had its own dedicated space and time. So we pulled it out last year and put it into a half-day workshop. You can see this picture is from one of the little activities that they did. So even this year, we're looking at expanding it further, possibly making it a full day, working with our PDI Institute here at Tampa General. Our fellowship fair and primary care and hospitals fair used to be two separate events that occurred at night after hours. So some residents had challenges making it to those based on their clinical rotations and things that they were on. So this last year, we turned it into a workshop again. So it was a PGY2 kind of career and leadership development. So there's kind of combined topics at the start, prepping for getting your medical license, building a CV, and then they kind of split off into two different segments of the workshop, whether they're interested in fellowship or not. So again, planning on continuing that modified workshop again this year. New kind of curriculum related to in-basket management at Health Park in Morsani that's launching in January. Another big kind of update and change is at TGH, the CCU rotation or cardiology ward rotation really needing to be modified to kind of fit within the change that TGH is having globally at the hospital with transitioning to closed ICUs, with the next one being 2D. So we've already kind of started a staged transition. November 1st is the planned soft closure, and soft closure means all of those patients will have critical care anesthesia as the primary. So our team will transition to kind of serving in, I guess, more of the consultant role, but really it should be seen as co-management of these patients. And full closure will be in January, when there's going to be 24/7 intensivist care in-house within the unit. So the current state, we are working on transitioning from our combo team, right? We have a hybrid team that cares for both floor and ICU level patients. So to start preparing for this transition in November, starting this month, we're starting to kind of trim down the amount of floor patients that we're seeing on that service, because that number on November 1st is going to go down to 0, because we're going to be fully in 2D. So we're really looking forward to this. All of the planning meetings, everybody's been very collaborative, from USF cardiology and TGMG cardiology, critical care anesthesia. They're planning daily conferences. They're looking forward to supervising procedures for our residents day and night. They have already launched multidisciplinary and interdisciplinary rounds. I know it's a little bit challenging in our current model right now, because we also have floor-based patients that we're rounding on. But starting November 1st, when all of our patients are in 2D, I think it's going to really make it much more cohesive to be there for the interdisciplinary rounds on all of the patients there. So obviously, as that transitions, we'll be watching closely, and please send us feedback if there's things that need to be worked out or tweaked along the way with this transition. The next thing I want to talk about is a GME-wide initiative. So this is SAFER, and I tried to talk about it earlier, and for the life of me, I couldn't figure out what SAFER meant, so I had to put it here because it escaped me at the time that we last talked about it. It's officially launching next week, and the purpose is to really strengthen the quality of handoffs using structured observations. So we're going to have residents on the Safety Council observing handoffs. We have to report them back through this program to GME. And then also something unique is this standardized safety question that we would like you to include in all of your handoff conversations. And just a reminder, handoff should include both the written, electronic, usually tool within the EMR, as well as the verbal handoff at the same time. So handoff isn't complete with only one of those two aspects. To show you what that observation is looking for, here's kind of the grid of what the observer is going to be filling out. And you can see here the safety question that you is either the person giving the handoff or receiving the handoff. We would like you to start using is, what safety concerns or near misses occurred during your shift? So whether you're handing off to the house officer, leaving, and you're leaving that day, or you're coming in the morning and you're getting feedback from the house officer, right? Did any safety events happen on your shift last night? And it might be hard in the moment to to really recognize, is that a potentially a complication that could be known from a procedure, or was this really a safety issue? So if you have any concerns, our goal is to really take these safety concerns and put them in the reporting system. So if there is something that's reported to in the handoff, I think the next question should be, did you put in an incident report? If you're ever like, I don't know, is this something that, would be an incident report? That's where I would recommend reaching out to our patient safety catalysts. So we have one at each of the 3 hospital sites. So if there's ever a question and you're like, I'm not sure, or wow, this was a really important safety event that came up last night, I think it needs more urgent attention, please route it to one of our 3 residents here, based on the site that it occurred in, because they will also bring it up in our GME patient safety huddles as well, or help you put in that incident report if you're unsure of how to do it. And they are tracking incident reports. This is kind of per monthly since 2022. You can see when GME had a prior initiative related to event reporting, it really kind of bumped up event reporting, from the program globally. In terms of work hours, some changes. Last year, the phone call with the interns for those on wards really improved kind of day off timing for the seniors that are on wards. This year, we updated the VA flex rotation to shift that cross cover to a Friday night instead of a Saturday night to give more of a weekend. Even though technically there was a 24-hour period off, for our residents experiencing it, it didn't feel like a day off. And then last year we added the VA Ward Assist to help with after, the PM call team efficiency. And we'll be collecting data this year to see if it's truly helpful, to see if it's something that we would continue in the upcoming year. Some other fun initiatives. We switched the intern coaching team this year to a big SIB program. We had the family medicine residency join us and have a combo team on team E. Next year, we're anticipating that they're going to be a whole separate team once they have seniors. So they will be team F. At this time, we're planning that we'll still keep our Q5 call schedule, but that they would have kind of prescribed days within their week that they would join in on call. So every now and then when you're on long call, you might have 2 teams on long call, knocking it out. Some other rotational stuff this year for the intern MICU experience. It was split. So instead of 1 month at either TGH or the VA, everybody had 2 weeks of both sites, similar to the year prior when we did the CCU card ward split. And then we also added within that rotation a couple of night shifts at Tampa General, again, for kind of earlier opportunity exposure with ICU level admissions, procedures, and kind of acute management issues that come up at night, and to kind of get more facile with that prior to transitioning to being a senior resident. Now, here's Rob Lowe. Let's see if I can do this. I have to play the audio from this side. So something that is really fun that we're playing, and I don't know if anybody's seen the floor. Has anybody seen the floor? I know I asked you guys yesterday.
Is the game show?
The game show.
Yeah, I've seen it.
Okay. Well, let me pause this. So in board review, in April for the PGY3s, part of that day is going to be literally playing the floor with board review. There will be money. Okay. So it'll be really neat. So residents will have, a little topic that they may have to duel on to gain more floor space, right? They have to duel with each other until somebody's kind of won all the duels or like gotten all the floor space. It's a cute little game. It premiered last night, so. And then just a final reminder on feedback. We haven't made changes this year with the feedback structure. It's still the on-the-spot feedback form that residents are expected to complete on every single rotation. And then in new innovations, they would assign their evaluators to their core rotation. So wards, ICUs, things like that. And then just a reminder for the faculty, you do have the ability to select a resident within here. So if you're waiting and you're like, I don't have the evaluation yet, you can launch your own evaluation. So you would go to create evaluations, you would type in the resident's name. I think I picked Hamara. You would pick the type of evaluation you wanted, like a ward evaluation, and then you would be able to complete it. So as attendings, you can launch these yourselves. If you're kind of in your in-basket or you're like, I'm kind of the person that likes to do it on my last day of the rotation with that person, then you have the ability to launch it yourself. For our residents, right, you would launch it the same way. So instead of kind of choosing a subject, you would say request an evaluation and go through the same process. And then just some final words and thanks, thankful for all of our program leadership. These are all of our APDs. We have 3 new faces with us this year that we're very excited about their contributions to the program. We have wonderful administrative leads for the program that really help it run day in and day out. Our PGY4 chief residents, our PGY3 chief residents, again, really help us run a lot of the behind the scenes and even the not behind the scenes work with running the program. I want to thank our faculty. They do so much for our residents in terms of teaching, giving workshops, board review, simulation training, ultrasound workshops, code blue simulations, building community events, wellness events, career mentorship, our fellowship fair, primary care hospitalist fair, interest groups, research groups, scholarship, QI. Like I could literally keep spewing everything that our faculty do. And I'm so thankful for you because obviously to run a program, it takes a village. And I definitely couldn't do it myself. And I don't do it myself. And then finally, thankful for our residents who are the heart of our program and really are what drives the culture that we have here. We nearly always win the Student Clerkship of the Year award. And I think it's largely because of our residents, right? Our students are with you way more than they're with us. And so our residents are wonderful educators, leaders, researchers. They support each other. So again, so thankful for everybody in the program who helps us, keep it moving along the path. And with that, I'm gonna switch gears to Colleen.
Does anybody have any questions in the chat before we move forward with introducing Dr. McIntosh? Okay, Dr. Oller got all righty. So I am super excited to introduce Dr. McIntosh. So just a little bit of a background for Dr. McIntosh. She came here via Philadelphia College of Osteopathic Medicine in 2015 when she then joined us for her internal medicine and pediatric residency that she graduated in 2019. She joined USF Hospitalist Maine as part of our faculty for several years, and then ultimately did transition. TGH slightly stole us, but she still works with us as adjunct faculty, thankfully, in 2022. She is an absolute expert when it comes to clinical documentation and improvement. She continues to give several lectures for our residents on this exact topic. She also just recently did a similar lecture to even endocrinology grand rounds. So we're very, very excited that she's going to be here today to discuss this with us as well. The other little side note apparently is she makes amazing crab cakes. So if you're interested in crab cakes, probably want to hit her up for that. But thank you so much, Dr. McIntosh.
Thank you. Thank you guys for having me. I do make amazing crab cakes. I am originally from Baltimore, so go Ravens. I have no disclosures. So the objectives today is at the end of this lecture, I hope that you understand the significance of clinical documentation during training and residency and how that's going to apply to you in your independent clinical practice. My top objective today is to get everybody excited about the upcoming implementation of the system-based practice curriculum here at USF Internal Medicine Residency. And then for those that are not interns or even in independent practice, maybe identifying gaps in your own knowledge. And I hope that I help you discover approaches for ongoing education. What you will always be against me. Is my mic on? Okay, perfect. All right, these are the objectives. All right, so I always like to start with cases. This is actually a resident case that we saw. So it's a 40-year-old male, past medical history of type 2 diabetes, hypertension, metastatic pancreatic cancer, presents a worsening abdominal pain. He was recently admitted for a new diagnosis of metastatic pancreatic cancer with mets to liver, spleen, peritoneal carcinomatosis, and he was discharged on by mouth pain medication. His pain has been uncontrolled on his home regimen. He was admitted to internal medicine for pain control. His vitals are there. He's slightly tachycardic, and he's experienced a 20-pound weight loss. Physical exam is pertinent for a distended abdomen with a positive fluid wave, and his laboratory findings are there. Unfortunately, this gentleman passed during his admission. He was given his first round of chemotherapy, and the complications, he unfortunately passed. So in his H&P diagnoses, these are the diagnoses that were listed as the H&P of metastatic pancreatic cancer, ascites. We had noticed some weight loss, and then it was documented a failure to thrive. From a Vizient Academic Medical Center ranking, this patient should not have passed during his admission. He had a low risk of mortality, or how we call it, below. However, if you look at the documentation and you look at the clinical case, you realize that metastatic cancer is not coded unless you actually name a metastatic site. You also understand that cancer-related pain is a significant risk adjustment and adds to the complexity of your patients. You would understand that weight loss, failure to thrive, anorexia, underweight don't actually code, and that's actually protein calorie malnutrition he met for severe, which significantly risk adjusts his complexity. Because he has cancer and because he has severe protein calorie malnutrition, he meets criteria for cachexia. And really identifying patients that have cachexia, you know that they're at risk for things like chemotherapy, and they have poor outcomes with really harsh medications. And for labs, apparently hyponatremia risk adjusts. I don't make up the rules. These are the coding guidelines. But after completing the documentation for this patient, his risk of mortality increased. And now he had a significant risk of mortality during his admission. I will give this resident credit. He got a majority of these diagnoses. I kind of played it up for grand rounds, but there was cachexia and hyponatremia that really pushed this case to the above. We're going to switch now gears to a billing case. So you evaluate Ms. Koreg. I made up this case, during her admission for heart failure. She is now euvolemic. She is pending confirmation of her SNF arrangements. Unfortunately, she does not have insurance. You discuss her options in MDR with case management. You also note that overnight she lost 6 pounds. So you held her Lasix for today. You do not review any labs for today. Today was an off day in her labs, and she didn't need criteria for any labs. So what is the most appropriate billing code for today? You would obviously code a level 2. You understand that she's at moderate risk because she does not have insurance, and that puts her at moderate risk. You also adjusted her prescription medications, which is a moderate level that you performed for her today. And you very appropriately documented that you discussed her options with case management, which means that that is a moderate amount of complexity that you did for her and meets for a moderate level. And I hope everybody here builds a level 2 and did not bill her a level 1. Because you understand that now you have lost RVU capture on this patient for inappropriate billing. Great question. So it's not a 3 because she is currently euvolemic. So her risk of her heart failure is now low because she's now euvolemic and you've documented euvolemia. You don't have enough of the amount that you've done for her, or at least you didn't document the amount that you did for her. So I don't have on here that you reviewed any notes. I don't see that cardiology has seen her, that you reviewed a cardiology note. You did note that you have no labs to review today. Did you not? I don't know. If you didn't review any labs, you didn't document it. You didn't say that you reviewed any notes. You didn't talk to any family members. You didn't bill on time. So you may have done more things to justify a level 3 billing, but this is the only thing that I have documented. This is all I can bill off of. But that's a great question. And I owe you some money for a great plant of a question. So now we're going to go into why does documentation matter for physicians? So these are the top quality rating agencies that academic medical centers benchmark themselves against you. So I hope that you've heard of names like Vizient and Leapfrog and US News and World Report. The ones that are circled, these are the domains that are directly impacted by documentation. So even if you graduate here and you're one of the 60% that don't stay within USF or TGH, the odds of you going to a hospital or academic medical system that still uses one of these ranking systems is very high, because these are pretty nationwide, and really most centers use these to compare themselves and benchmark to other academic centers. So it is to your benefit to understand what they look for in ratings, how they measure quality, and how your documentation is impacted by those. And before I get the question of Dr. McIntosh, my note has never saved a patient. And I hear you. I absolutely hear you. But what you don't realize is that mortality and length of stay are reported to these agencies as a ratio. So you do have the observed, which is the number of patients that pass during a quarter. And here at Tampa General, we're in the top 3rd percentile of the patients that actually pass in our hospital, which is world class. But again, it's presented as a ratio, and it's benchmarked as a ratio. And the bottom, your denominator, is your expected. And your expected is directly related to the problems you're addressing in this admission and the comorbidities of that patient. And that is 100% on your documentation. And here at Tampa General, because I have the data, we are in the bottom 9th for the expected mortality, which means one of two things. One, we are a community level hospital, and we don't see very sick patients. Or two, we don't do ourselves enough credit and document the complexity that we see. And remember, it's your denominator. So the lower it is, the worse your actual ratio comes down. So it's to our benefit to really document the complexity that we see in front of us, to really give ourselves the credit of the patients that we take care of and that we save with our world-class care with our observed mortality. The thing I also want to throw a bug in your ear is we are seeing an exponential increase in insurance denials. We do not have the data here. I hope to have that data in the next 3 months or so about how our insurance denials are doing, both inpatient and outpatient. But insurance companies are using AI technology to screen charts and send automatic denials. And so their numbers of denials, both for inpatient stays, this is for a diagnosis-related group from a different health system, they're exponentially increasing. And what are they scanning the charts for? Your notes. And so if you don't say the complexity that you're putting in the note, and you don't justify why this patient needs this care in this location, there you have an increased risk of denials. And this doesn't impact you not only here as a resident, but also in clinical practice. If they're not willing to pay for the services and your patient now gets a huge bill because that has been denied. And don't get me started on the automatic denials that are coming for the outpatient side. Don't get me started. So why is it important for you as trainees? So this was a pre-survey done with 43 USF, IM, and MedPeds residents, and we asked them 2 questions on each of these topics. And this was probably in 4 months ago, so this is pretty recent. Clinical documentation, 64% correct. Inpatient observation statusing, 67% correct. And billing and coding, 40%. So we know that there's an area of opportunity to improve some knowledge in these areas. Why does it matter? Because this is a really great program. USF Internal Medicine, and looking at the GME survey for postgraduate, both IM and prelim, they strongly recommend this program in 9 out of 10 topics. And what is the one topic that they wish that they had more education on? And that is billing and coding. And so that is our mission, to really develop something that you understand why you need it and something you can apply the moment that you graduate from here. And so how does this work? So this is going to be a curriculum that builds on top, and that is cumulative, starting at first with documentation. As we brought up in the first case, it doesn't count if it's not documented. So before we do anything about billing or statusing, we have to know how to document that really shows complexity, and you get credit for what you did for that patient. So that is going to be first, and that's going to be really hit hard in your intern year. And then we're going to PGY2, add on inpatient observation mission status. Why does this matter? Because you really need to understand, now that I've captured the complexity of that patient, where am I best caring for this patient? Am I caring for them in an outpatient setting? Am I caring for them in an observation setting, in an inpatient setting? What meets the criteria between the three, and where is best for that patient to be? And how do I justify that patient needs to be in that status? And then once I have documented my complexity beautifully and I've justified the status that need to be in, how do I bill? How do I get credit? How do I show what I did for that patient? How is this different than other programs that have been in the literature? It's not new to teach these things to residents. Most of what's out there in the literature is segmented. So they either do documentation or they do billing. And I'll be very honest, I haven't seen a lot of programs that do statusing. But they do one or the other, and it's usually finite. So they give it once, they mark it over 6 months, look, we've improved, and then they move on. And there was one poor soul of a place that did a 5-hour lecture and then looked for benefits. And I will tell you, it didn't work. But it's usually finite, and it's usually in one area. There's not really a lot of education that really builds on top of itself and is really cumulative over those years. This curriculum is developed and given by your peers. So I don't build this curriculum on my own. I don't know the latest technology. I don't know what's relevant. I don't know what's meaningful. And I don't know if the message is coming across. And so I build this with peers, your residents that help me build this. In addition to giving you curriculum, we give you real-time tools. It's great that you understand malnutrition is important at noon conference, but at 3 a.m. when you have 3 admits coming in, are you going to remember to put malnutrition on there or their labs? So what can we give you real-time tools that when you're admitting that patient, the right choice is also the easiest choice? And then I really try to give you real resident cases. Miss Corrig is a funny case to review, but you need something that's relevant. You need to review a case that you saw and I say, hey, this met for below mortality, and here's how things that we can do to improve. So this is what your roadmap looks like. Starting this year in PGY1, we're doing a formal lecture on education and documentation. I know everyone just wants to kind of survive, but if we can start to really embed this education as you start to, even in your intern year, by the time you graduate, it will become second nature to start documenting for complexity if we start really in the intern year. So formal education happens now. Really, that dedicated academic half-day case review is going to happen in February, March. Just as a reminder, here's how we apply it, here's how we're doing, and it's for everybody. Before you become a PGY2, you're going to get formal education on statusing, because you're going to be taking the calls from the ER, and they're going to ask you, inpatient, observation, or you may even look at them and say, hey, I don't have enough to justify this patient in this hospital. Maybe we should do things like TAF. Maybe we should do things outpatient. Maybe I can help you arrange because I don't think I have enough medical necessity for that patient here. And I hope we get to that point where you can understand those different degrees in those different areas. What we really hope to incorporate in your second year academic half day are those denials. That patient was denied an inpatient stay. Here's the bill to that patient because they weren't met for medical necessity. Here's how it impacted that patient, that it was denied in the back end, and what we could have done to further justify that medical necessity. PGY3, you guys are going to be graduating soon, and you're going to have to know how to bill. And if you go to a place that has an RVU requirement, you're really going to know how, to bill, right? So really starting out PGY3 with learning, billing, and coding, allowing you that knowledge, those tools to start practicing billing and coding in your third year. Then before you graduate, a final review. Let's go through your cases. Let's go through some fine tuning. Let's ask those final questions. That way, when you graduate, this isn't going to be something new for you, that you leave here and you feel prepared. How are we going to measure success? I really like to do projects with metrics. Yearly, you're going to do an assessment like the one if you haven't already done it. 2 questions based on the topic. Do you have a basic understanding? Is something that we can track over the 3 years. For clinical documentation, we're going to look at the queries that you get. Are we proactively documenting these complex diagnoses so you don't have the administrative tasks on the back end and you get a query reduction? Also going to be looking at our diagnosis capture, and there are secondary metrics, things I cannot control, but our expected mortality, expected length of stay, and our severity of illness. For inpatient, outpatient status, we're going to look at our code 44s, and you're going to learn what that is. We're also going to look at the number of denials, but I have an asterisk next to it because I have a sneaky suspicion that our number of denials may still increase. And then fourth, we're going to look at billing and coding knowledge and assessment, and we are going to assess that yearly GME survey to see if we've improved in preparing you when you leave here in residency. Here is the resident tributes, as I call them, so the ones that are working with me to develop this curriculum. They really help me in kind of what should we present, how should we present, we should say it in this way, and then they're going to be the ones that are actually going to give the education. Because if they can understand it and they can give it to you in a way that that is meaningful to them, then hopefully you're able to understand and retain it. And then you work with them and they can ask you in real time questions and reach out to them. So if you have any feedback, find these residents, thank them for going on this journey with me and give them feedback. And if you would like to be involved, we are always recruiting. So how do I learn more? If you're sitting here and you're like, oh, I'm a third year, what am I going to do? I've missed 2 years of this. I have the next 3 slides are a brief summary. If you want to learn more, and I hope that we send these slides out. The last 3 slides is kind of a basic overview of documentation and for complexity. So these are my never missed diagnoses. I've already talked about malnutrition, things like failure to thrive, underweight. They just don't code. They just don't mean what you think that they mean. Even sarcopenia, it doesn't code. It really needs to be malnutrition. It really helps with severity of mild, moderate, and severe. And again, if they have a chronic illness, you really want to capture that cachexia, especially if they're muscle wasting. You really want to capture that because that does really risk adjust your patient. And you know clinically that patient is at risk for complications and has a clinical risk of mortality. Altered mental status and confusion doesn't mean anything. It just doesn't code. Your term is encephalopathy, and specifying it will really help you. As I mentioned, metastatic cancer, it doesn't code if you don't name a metastatic site. Stage 4 doesn't mean anything. Metastatic pancreatic cancer, it doesn't mean anything. You have to name a metastatic site for it to code out and get credit for that metastatic cancer. Shock, significantly risk adjust for obvious reasons if somebody is in shock. So hypotensive, if they're on hypotensive and I'm sending them to the ICU for pressors, maybe we should evaluate them for possible shock and specifying which type that it is. CHF, you're going to get queried about it all day unless you specify the acute on chronic, and then usually their EF. Even if it's unknown, that's okay. You'd have to specify your acuity for CHF. Coagulopathy significantly risk adjusts your patient. If they're thrombocytopenic, if they're hyper coagulopathic, or they have a coagulopathy secondary to maybe liver disease, significantly risk adjusts. And then AKI, renal failure. And then don't ask, I didn't make up these rules, but your hyponatremia, your hyperkalemia, all of your labs significantly risk adjust as well. Here's a review of all your statuses. I'm just going to leave this here. I'm not going to go through all of them, but we hope to give you something like this for when you actually do status. When you have a UTI, what really meets for an observation, what meets for an outpatient, what meets for an inpatient UTI, and what are some parameters that you need to be looking for. So we hope to give you this to really help you as you take the calls from the ED. This is billing. So I'm not going to go through all of this because I've hopefully kept everybody awake so far and hopefully online. But this is kind of an overview of what you really need to document when you're looking at things for billing, and how much do we do on here that we don't actually document? Do we document all of those stable chronic problems and those medication managements that we do on rounds? Hey, we need to increase their core reg. Hey, we need to hold their Lasix. Do we document that we did all of that? Do we document all of the consult notes that reviewed? Do we document the case managers that we talked to? All the labs that we reviewed, all the labs that we ordered? All of that counts, and you should get credit for the work that you do and the patients that you see. Do you understand that a person on a heparin drip is at high risk? Do you understand a person that's requiring IV narcotics around the clock is a high risk, and we really should be billing that level of risk that we see in those patients? So these are just kind of some overviews. And this is my last slide. Thank you so much for giving me this opportunity to come and talk, and I hope that I did make everybody excited about this. I look forward to going on this journey with you, and happy to take any questions. Yeah, no.
Dr. Kim.
Yes.
Thank you, Dr. McIntosh. Once again, clear, wonderful presentation. So, the younger generation, they're so good with AI and things like that. And obviously, we have patient confidentiality, proprietary rules, all these other kinds of things. What do you think, and how are we going to incorporate AI? Because I think that's the move of the future as far as documentation, differential diagnoses, how to use it well so it's an important tool rather than an inappropriate crutch.
Yeah, no, I love that question. So I believe Dr. Kapadia offered to help me fix that problem, but we are bringing AI technology for hospitalists here at Tampa General. Because AI is able to pull out diagnoses, not only from this encounter, but also across multiple encounters. Things that we do miss, like AFib 2 years ago, it's able to really pull that out if somebody's coming in with a stroke, whereas we would spend hours chart diving in the EMR. So that is coming for hospitalists. I'll be very transparent. I don't know the opportune time to give that option to residents. And I also can't guarantee that if you leave this residency here, you will go to a place with AI. So you will have to learn how to do long division. You will have to learn how to do, you will have to learn how to document. You will have to learn how to recognize and understand that if I'm putting altered status, it's not going to do anything. Because even if the AI offers you up encephalopathy, you may be like, nah, that'll be fine. I'm not going to include it in my note. So I think it's going to be a balance. I think the technology is coming here. I'd be very open to working with anybody to really say, how do we give what we call a calculator? How do we give that to residents where it doesn't compromise learning and it's added to it? But I do think that it's out there. But I do want to make sure that we are very thoughtful about it, especially for incorporating into residents and fellowships.
Residents will be working with Dex Copilot in the outpatient setting. So there will be that opportunity there. It's more of ambient listening and helping to document the conversation per se. So I think it might be a little bit different than what you're kind of referring to in regards to the AI.
Yeah.
So it is more of like a very sophisticated dragon.
Yeah. Yeah. So that one is the one that we're looking at is mining for diagnoses.
I just wanted to add on that, for some of us were brave enough to sign up to be the AI ambassadors, and the tool that just opened up this week is an AI summarizing of the notes of the chart. And I can already see like its biggest fault is that it's summarizing bad notes.
Yep.
So, if the notes were better, I think it would be an exceptional tool, and I've put feedback in, but the truth is it's summarizing notes that are not the best at capturing the patient's complexity and what's going on. So I think that will be another incentive moving forward for us to really improve our documentation skills. And if you're not using Dex Copilot, highly recommend it. It does teach you, like if you don't know what hallucinating is, you'll really get a good understanding of AI hallucinating. But for my anxiety disorder induced from documentation, it's done wonders.
There's lots of us CMs, Colleen, myself, I'm assuming that's Cook Mai, yeah.
Yeah, not Colleen McIntosh. Colleen, I was wondering, you mentioned kind of the increased number of denials on the outpatient side. Has the organization looked at whether DAX Copilot plays a role in those denials at all?
So I think that's a great question. I think we're going to learn more about it as the coming weeks. So Cigna recently announced, starting in October, they're going to automatically downcode their high-level codes, especially on the consultant side. So automatic downcode, you have to physically appeal. The initial advertisement says that it will not impact a majority of people. We will see what that looks like. We will also see what criteria they're looking for when they do those automatic down codes, because they are obligated to say why we are or are not coding the code that the physician felt that they deserved for that visit. So I think there's a lot more to come from there, but they are utilizing automatic downcoding and AI. I hope that if we get to a point where we are documenting accurately what we do and the complexity that we see, we will get less in those denials, or at least able to have support for overturning them. And then we can start to really look at payer behavior. But again, it all starts with what we put in our notes and making sure that we not only document the complexity and the justification of our services.
Yeah, I just wonder, because I think with the DAX Copilot side, I'm wondering if we're losing some of the documentation on the complexity of what we're doing in the assessment and plan portion of it. And especially when we're rolling it out on the inpatient side, whether there is going to be a proactive look at the O to E on the mortality side. I'm curious about that. I think it does a really good job of H&P. I'm not so sure about the assessment and plan portion.
Yeah, I'm willing to look at it, and especially as we start all this together, looking to do that assessment.
Actually started having conversations with Dr. Robert Ledford about this, since he's, one of our clinical reasoning masters that's in our program. I think the one thing that we really are going to have to emphasize is really probing our learners to understand their clinical reasoning. I see nothing wrong with utilizing AI tools. I use them, we all use them, but we also have, for some of us, decades of experience to be able to recognize when AI is giving us an output that may or may not be accurate. And it's a little bit easier for us then to dive in and be a bit more discerning in regards to the information we receive. And so Bobby and I are talking about developing some sort of workshop curriculum along the lines of like, how do we ensure that we're seeing you guys show your work, just like that long division, right? Like we want to see you showing the work, and to ensure that you got your clinical reasoning is actually solid, and then you just weren't lucky with a good guess. Because we don't then want you applying it to a different patient population where maybe that wouldn't be the appropriate response or treatment, et cetera.
Thank you.
Yeah.